In particular, we acknowledge the traditional territories of the Ojibwe.
To gather, though virtually, on this land, and we thank the generations of Indigenous people who have taken care of this land long before other nation groups came. In particular, we acknowledge the traditional territories of the Ojibwe, the Anishinaabe, and the Mississaugas of the New Credit, whose territory is covered by the Upper Canada Treaties. We also recognize the contributions the Métis, Inuit, First Nation, and other Indigenous peoples have made in shaping and strengthening this province and this country as a whole. We also need to continuously educate ourselves about the colonial history of this country and understand how the wrongdoing of the past still impacts the present and the future. I encourage everyone at this session to actively seek information and take action. Thank you. So I'm gonna check.
Well, thank you very much. So as introduced, Dr. Deji Ayonrinde, and we're really delighted to have our colleague, Dr. Bola Ola, Professor Ola, also connecting from Nigeria. He's done extensive work, and in all modesty, he may not say, but his PhD thesis was around sickle cell disease and mental health. So Professor Ola is going to be keeping it real with a number of case scenarios and give us really helpful and important insights into the experiences of people living with sickle cell disease and how some of these experiences can affect mental wellness. I'm not going to say the words for him, so welcome, Dr. Ola, and very much.
Yeah. Thank you very much. The lived experience of people living with sickle cell, because I have cousins who live with sickle cells, and I see that most of the times they are being denied a lot of their rights, rights to care, rights to be listened to. So I became interested and I wanted to learn more on how to actually advocate for them. So that took me on a journey to my PhD in the UK. So I'll be glad to share with you some of the findings of my work, and it's really reality-based. So we can go to the next slide, where I will be talking about the burden that Nigeria is in West Africa. You could see it just at the you can see the red color where it shows that the newborns with sickle cell anemia, they are up to between 10,000 to 100,000. And in fact, Nigeria has the highest absolute number of people with that in the world. Next slide, please. So we could see that the red color is showing the frequency of the genetic information that is carrying the sickle cell disease, and it's quite high also in Nigeria. You could see it in West Africa, and that's very red. It's over 14%. Yes, thank you very much. So we go to the next slide. And this is just to let you have a feel of the picture that speaks, I mean, more than 1,000 words. And it's to show you that this country carries 66%, that's close to 70, which is about 7 out of every 10 of the burden of people living with sickle cell disease in Africa. In fact, the carriers of the gene of sickle cell in Nigeria, it's about 24%, which is about a quarter of the population carriers of this gene. And every year we have about up to 150 infants that are born with sickle cell disease. And quite unfortunately, about 70 to 90% of them die before the age of 5. And then you could see that Nigeria takes almost 50% of the share of about 300,000 babies that are born with this hemoglobin disorder globally each year. Meaning that you are likely, as a person living in Nigeria, to come across someone who lives with sickle cell. The next slide. The next slide, please. Yes, so in my quest to understand some aspect of mental health problem that people living with sickle cell deal with, I had to look at one very common disease, which is depression. And looking at the literature, I found out that depression in people with sickle cell disease is being framed by the existing medical literature as within the person with the sickle cell, and that stigma is automatically associated with having sickle cell disease. However, looking at another framework, because that's just essentially too biological, the social framework actually says that you need to look at the person-environment interaction. And when we look at that, I was able to see clearly that people are disabled not by their condition, but by the social attitudes, the physical social barriers, and the social conventions. And it is very important that these social factors are considered if we want the quality of lives of a person who is disabled to improve. And so that led me to find out how are the social conditions of people living with sickle cell who might have depression. The next slide. So I had to use some questionnaires to identify people with depression. In fact, during the administration of the questionnaires and the feedback to people who live with sickle cell, some that had scores that, they were within the cutoff marks of depression. Some of them still argued that they didn't have depression, that the problem actually is with the society. But then this enabled me to pick those who I would say are biologically labeled with depression to actually examine the illness experience, where I had to do individual in-depth interviews for. And in focus groups, I had to also look at what are the social arrangements that could be causing depression in this people. 103 people that I recruited, 82 of them self-identified with some level of depression, ranging from mild to severe. And out of the 82, I interacted with 15 in individual in-depth interviews, and 10 of them took part in a series of focus group discussions with 5 in each group. So the next slide. What were the findings? And what I found basically was that almost all of them have been extensively subjected to discriminatory reactions from the family, their immediate family, the neighborhood, and where they work, and where they have to get treatment. In fact, within that study, what I found was the chorus of disapproval by every segment of the society. And the participants recognized that stigma was not from the condition that they have, but from the assumed broken to live beyond of age, without thinking about what social arrangements they could put in to make several of them to live beyond 5 years of age. And then because of the fact that a lot of them die early, the society also feels that they shouldn't be educated. And a significant proportion of the society would not want to employ people who live with sickle cell, and even parents are actually bothered when they have their children who have sickle cell, because they think that they would have to bury their children with their own hands, which is also some of the things that they have negative assumptions about. So, but then when I spoke with them in groups, they actually were able to form and decide together that they needed to challenge the negative assumptions that people have about them, and that they themselves have become used to that living it, because that is actually a social label that they are actually enacting. And then they recognize also that they need to have collective social interest as a group in order to dispel the myths that the society has created about living with sickle cell. And they started to rehearse during the groups. That's what I call rehearsing in backstage, the social actions that they might be able to engage in when actually interacting with others in the society. So that leads me to some of the case a series about that I'm interested in sharing with you today. Let's go to the next slide. So this first case, it's about Miss T, and she is a 32-year-old female with history of sickle cell anemia. She is actually a graduate of business administration in one of the universities in Nigeria. She was married and had her first pregnancy as at the time I was interacting with her. She wasn't in any symptoms of distress. She had normal body weight and parameters. There was no physical characteristics that would show that she is someone with sickle cell disease. From the parents, the father first had to tell the mother that he was not the person who impregnated the mother, because he said he was from a family where none of them had children like that. So that was the beginning of the problem. It was a big challenge, and the father and mother engaged in different aspects of domestic violence, emotional abuse, sometimes physical challenges, because they were fighting over her, and she tended to see herself as the cause of problems in her family. So when she had to marry just to get away from that problem of the family, and even when she got pregnant, she was afraid to go to the hospital because she had grown up to see that people who have sickle cell, they don't actually give them a lot of respect. In fact, she felt that if people know that you have sickle cell, they would be they would assume that they need to control you, to tell you where to be, where not to be. She had all eyes on her. She wasn't as free as other people that did not have such condition. And she said that this is just an aspect of me. This is not the total me. And then she grudgingly accepted to visit the antenatal clinic. And that was when she was about 28 weeks pregnant. So when she got to the hospital, the doctors looked at her somehow and shouted that, why are you coming at this time? And you know that you are actually giving yourself a death sentence by getting pregnant and not visiting the hospital. So all that they told her in this first day of the clinic was all negative things that would cause a lot of fears in her. She would had a lot of anxiety and nobody was there to actually counsel her. All the healthcare workers had negative attitudes towards her. And she felt that this was a condition that if anybody lived through that condition, definitely you would have some problems with anxiety and depression. So she illustrated that experience, and she said that she decided that she was not going to go back to that hospital. So by the time I was meeting her, I had to let us see that the problem is not within ourselves, but within the structure, the social structures that have been arranged in such a way to discriminate against her because she has a condition, and then they have certain negative expectations about her. So while I went with her through the hematology clinic in the Lagos University Teaching Hospital, and I got someone with some experience that had to go with her to the antenatal clinic with us, and she had a change of perception, and she was actually handled with care, and she became happier. In fact, along the line of my investigation for my PhD, when I re-administered the questionnaire to her, she never scored. She scored within the normal range of people who do not have depression. In fact, she also told me that before she even got married, she would, because of the chorus of disapproval that she has been hearing, she would attend parties, she would drink alcohol, she would smoke because she was thinking that maybe while she is drunk, while she's confused, she could actually come to die, or maybe by a road traffic accident and things like that. But all that changed when she was able to get a husband who showed a lot of interest in her. In fact, at this moment, she has 3 kids through some promotions in her place of work. So I don't know whether I could stop here. If some of these things that I've shared resonates with you, the next session. Can you hear me?
Yes, we can hear you. Your picture's a bit, frozen, like pixelated, but we can hear you.
Oh, sorry. So what I said was that she's been able to, within a marriage, within the family, she has a very supportive husband, and she has a very supportive mother-in-law, and she's been able to have 3 kids now. All of them are in school, and she's been able to go to work and pass through promotions, and she's been at a middle management position in her place of work, and she's actually And what that represents is that she's broken the norms that they don't die early. She's about 40 years of age now, and then she's been able to live without having crisis. She uses her medications well, and of the society. So she's broken the norms that the negative social expectations that people have of them. And she's a role model for people who join the Sickle Cell Club, and that they also find out that most of the attitudes, most of the expectations of the society to them is actually wrong. They don't die early if there are indeed social systems, social arrangements or rearrangements that cater for them. So that's what I just said. And so before I go to the next slide, I don't know whether you might want to pass one or more comments about this.
Hi, Dr. Bola, and thank you so much for the presentation. It's Lanre speaking here. Amazing story. I myself, my brother died from sickle cell complications in Nigeria while living in Nigeria. It was about 30 years of age when that happened, but you're right. There are so much advances in care and treatment, and individuals with sickle cell disease are living longer. Even here in Canada, we have a 92-year-old, we have 74-year-old. So yes, people are living longer, but I think I like the idea and your work around not just that they're living longer alone, but also showcasing the stigma that brings about the, the mental health complications also around sickle cell disease. The chair of our board, I'm not sure if he's on this call, has actually declared this year as the year of mental health and sickle cell disease. It's a neglected aspect, and one that we need to take more, that we need to pay more attention to. So thank you again for this presentation. Yes, people with sickle cell are living longer, but we don't want them to live longer with mental health complications due to stigma, judgment, and even the disease itself, this is disease complications. Thank you.
Thank you very much, Larry. And it's been quite wonderful. Some of the things that they tell them is that they have these metaphors that they expressed to them. One of them is that they are baskets that when you pour water inside the basket, then the water drains away. Those are some of the things that the society talks about them. So what we had to do was that even if they are baskets, what if you put leaves in the basket, or what if you put nylon paper around the basket? Then if you pour water into that basket, would it leak? It wouldn't. So that's one of the ways of rearranging the understanding of the society in such a way that they need to know that if we which they are all subjected to, is actually strongly associated with developing depression, anxiety, and a host of other mental disorders. So the social point of intervention for them is to reduce the negative attitude, to reduce the negative comments, and to enhance this strong network of support that they have, and that is actually reducing. It's not about the treatment of depression. You don't have to wait for them to be depressed at all. It is the social rearrangements that would actually keep this thing from deteriorating into the mental health problems that they are having. And actually what the literature says is that depression is in them. And what I found out that the depression is not in them, it is in the social arrangement that discriminates that disempowers, that disables them. So that's the point that I'm trying to make. And is one of the outcome of that is longevity, and another outcome is good, positive mental health, positive emotionality. That's the message that I got from that studies. I think to just illustrate some more. Thank you. Let's go to the next slide. I can't see the slide.
Give me 1 second, I'm sorry.
Okay, that's fine.
I feel like everything disappeared on my screen all of a sudden, so please bear with me 1 second. All right. Okay, so we should, let's see, so
it's up now, then the next one.
Perfect, and that is, oops, there we go.
Good, thanks a lot. So this next person is Mr. Ade O. He was 26 years when I met him. He was working as a printer, and he lives with sickle cell. He had a leg ulcer at that moment. And I think sometimes within 2 weeks, of his life. And the father was of the opinion that because of what people told him about those who live with sickle cell, he wasn't able to send him to school. But now he's just realizing that he has a brilliant child who could have been more educated because he had more information within some few weeks of interacting with me and my colleagues. So, but while it was on the ward, sorry, I'm back. I hope you can hear me now.
Yes, you were kind of cutting off.
Yes, it was the network. I just, the Zoom just went off and I just reconnected. I'm sorry, it's the network.
Thank you.
Okay. Yeah. So Mr. Ade was on the ward, and then when they were preparing him for surgery, the father decided that he wasn't going to allow them to go ahead with the surgery. And the doctors decided to ask them to write to discharge themselves against medical advice. So Mr. Ade called me and said that he doesn't like what was going on. So I decided to go to him and ask him. He said the father refused because the father said he had a dream, and the dream was that and he decided I wasn't going to allow him to go for the surgery. So I decided to ask the father, and he told me, yes, that's exactly the experience. Then I told him that, well, did he see within the dream that the child died? He said, no. I said, well, what if sorry. So I said, what if the alternative explanation is that that darkness is for you, it's an interlude to actually make enough adequate preparations such that everything would go on well? He said, well, listening to me, that would make sense. And I was asking me what would be the kind of preparations. I said, well, I think what we would need to do is to speak further with the surgeons, and also to speak further with other medical personnel who would be managing him. I mean, his son. So when we got there, the that the leg ulcer that Mr. Ade had was actually there without any provocation. Then they said that they are going to take another skin from another area of the body. And now he was also afraid that if they make another cut in another area of the body, someone who has one leg ulcer will now have two leg ulcers. And it doesn't make sense to him. But then the surgeons were not psychosocially oriented, really. And they said, well, that is what they do. So I had to explain to them that what are the options that are available for this person. And they listed the options of deep skin graft to the options of very slight skin graft. And I told them that, okay, fine, why would we want to, I mean, maybe we should just take the very slight skin graft. And the father agreed to that at least that wouldn't be like a deep wound, it would just be something like a scratch, which they told us. And so the father accepted that he would want that to go ahead. Then we had to go to the hematologist, who also recommended that Mr. Ade should go through certain levels of preparation from their own perspective. And when all those preparations were made, in fact, the father, the mother, and Mr. Ade himself, they were very confident that they would actually go for the surgery. And they went for the surgery, and Mr. Ade is still sending me that language. And what actually is of note there, it's part of my message that it is actually the social rearrangement that would make the quality of life to improve. If it hadn't been for that social rearrangement, they might actually have caused him living in leg ulcers. He wouldn't be able to walk because he would be having pains. He wouldn't be able to engage in certain other things that would also cause a lot of stigma for him. But then with that social rearrangement, we could see the impact on his mental health. So let's go to the next slide so that I can just talk more and make an advantage of the network. So the next person is Miss Shola. She is a caterer, and but she also has leg ulcer. And she shared a story of the fact that she couldn't actually make a living even when she decided and she begged. She actually begged for money in the streets, and she actually used the money to train herself as a caterer. However, because of the frequent crises and the leg ulcer, when people come to actually be brave, let me put brave in quotes, to give her a contract appliances. So she would find coal, charcoal to be able to do these things. So because of such level of high stress, she breaks down easily to the extent that she might not even be able to put the icing on the cake. And so that is a downhill path for her. And she actually wasn't able to sustain herself because she had no earnings. So what we did was that to have a kind of joint pause for her. And then she was able to get some of these electrical appliances. And then she was able to make some cakes, and also went for surgery to treat her leg ulcer. and then she's been having it stable for the moment. So it's not the sickle cell that was the problem. It is actually the social situations and the social appraisers that actually denied her of what I would call a human that is very, very pertinent to having this condition and living with this condition, and because it's something that has to do with ability, but then it is the society that needs to recognize that by certain structures that they have, they are disabling people. For instance, Ms. Shola, if she was able to get the electrical appliances without subjecting herself to that level of stress, then she would also be able to earn a living just like any other person who is in this world. So it is not the condition basically, but it is particularly the social arrangements. So she said that even before she learned the catering, she was a factory worker in the cold room, and they actually gave her some awards because she was very, very diligent. But she said that what they didn't know was that she was actually suicidal. She would stay in the cold room thinking that because of the excessive exposure to cold, she would actually die. And she said she wanted to leave this world because she felt nobody loved her. Her family abandoned her, her friends abandoned her, even people that should be patronizing her. She said when she left, she felt abandoned. And so she later on, during the focus group discussion, discovered that it was actually that she didn't have a problem. She was born into this world with challenges that any other person could also have. But the thing is that the kind of social arrangements that obtains in Europe, in some other Western countries, I'm not saying that, and that is not even perfect in Europe, because I know that a lot of people are encountering a lot of discriminations there. But then for those who have physical disability, they've been able to make staircases for them. They've been able to make adjustment of buses for them for transportation. And then why can't we, people who live with sickle cell, have similar social arrangements to improve our life? And that is the responsibility of not one person, but of the society. So let's go on to the next slide so that I can talk a bit more about that. I hope I'm doing well with time.
Yes, you have, if you can, about 5 minutes, if that's
okay. Okay, that's fine. So I'll just run through this. This person is a journalist, and the experience is with his wife, who never knew, because a lot of people with sickle cell had to remain invisible so that they could marry, because if the society knows that you have sickle cell, because of the attitude that they don't live long, nobody wants to marry them, because they would feel that, okay, once I marry you, then you will leave me and to suffer and things like that. So a lot of them remain invisible. They don't disclose their status so that they can actually live like other people because of the social arrangements of negative discrimination. So he married, but then later on, because he's now about 60 years of age, but his wife had now grown up that sickle cell is not a death sentence, because a lot of times she would, when he falls sick after learning that he had sickle cell, would also think for each sickness she would think that that would be the end of him. But it's later on that he saw that when she was able to show him more love and he was able to live well, he's been able to have positive mental health, to be able to go out to work, to engage in journalism, to engage in advocacy for sickle cell, and he's been able to meet up with the social expectations, including marital expectations. And that is something that he shares with people who attend the sickle cell club, that sickle cell is just, and if the society, if your family arrangement is socializing differently, then you would have the same ticket to good quality just like any other person. So I think I would like to stop there. I don't know whether I have one more slide to go. Let's just check. Okay, no, that's not mine. So you can go back. So what I would like to say, it's that these cases that I've been able to present to you illustrates basic that we need to have advocacy for a change in how people are socialized about what sickle cell is from the family, because this is the social point. These are the social points of intervention. I found out that in some of my researches that once people are familiar with what this condition really is, they tend to have positive attitude to them. And so socialization from the family is actually important. Having education that is improving. We in psychiatry talk about mental health literacy, but I also think that there should be something that is called sickle cell literacy. Sickle cell literacy should actually be within homes, within schools, within workplaces, such that people would have adequate knowledge, not that people who live with sickle cell should be pitied. That is not, that is condescending. People should actually change the social structures, and so to give an opportunity, or what I call ablement, for people with sickle cell to live as, within their human rights and be able to contribute to themselves and to the society just like any other human being. Thank you very much. I think I would rest here to listen to comments from you. Thank you very much for the opportunity.
Thank you, Dr. Ola. It's so interesting to hear this perspective, and social arrangements, I think, is my new terminology for 2022, and is certainly something related to sickle cell that I have a different appreciation for. So you've really raised some great appreciation in me, no doubt. So thank you very much. We're going to take a short break. I do know there are questions. There could be some in the chat. We're going to ask you guys, please, just to hold your questions for the Q&A to make sure we can just get through Dr. Ayorinde's presentation as well. And then it leaves us good time in the Q&A to have a good dialogue, and we don't have to kind of like stop and start. We can just kind of keep it focused. So we are going to break now for 10 minutes. It is 10:54. So please come back at 11:04. I will be setting a timer and looking for you guys. And thank you again, Dr. Ola, and we learned so much from you, and I look forward to the dialogue later in the Q&A time.
So when we refer to mental wellness, we're referring to a whole range of contributions: our physical, social, psychological, and spiritual well-being. And this may be influenced by a multitude of factors: our culture, our literacy, our support structures, and it's critical that we do recognize these. In some areas of medical practice, people don't lean so much into spirituality, but spirituality is at the core of so many cultures, and certainly many cultures of color. Next slide, please. So sickle cell and mental disorders, as we heard also from Dr. Ola, sickle cell disease can exist in mental disorders, and mental disorders can also exist in sickle cell disease. And I think one of the takeaway messages, certainly to our health professional colleagues, and also to reflect on within ourselves, is seek and you shall find. Next slide. And in doing this, we're really thinking holistically. So let's look at the family, all family members. If a child is going through difficulties with sickle cell disease, that can affect mom and dad's wellness and their mental well-being. The distress, the time spent providing care and experiences, it could affect the siblings, of course, the person living with sickle cell disease, and an emphasis that will continue with through this is the importance of early intervention. Early intervention, early intervention, early intervention. Next. Now, does this look familiar? So let's talk about anxiety. And for those who have never experienced anxiety, and I'd be surprised if no one has, it's a whole range of different symptoms that come together when we call it an anxiety disorder. Some people may feel, oh, they're under stress. They find it difficult making decisions. Yes, but no, but, and so on. Difficulty swallowing, the heart beating with palpitations, trembling, sweatiness, feeling like running or having jelly legs, restlessness, nausea, or losing their appetite. Some people get so anxious they puke, feeling breathless, sleep disturbance, mind racing. And for many people, just listening to the news, the international news at the moment, there could be a fair bit of anxiety going on for them. Next. Next, please. Right, a quick disclaimer on this. I will be using two tools. Now, this is just to show you what the tools are rather than using this to assess you. So this is a clinical disclaimer, but this is something known as the GAD-7, generalized anxiety disorder, and it's got 7 items. It's a tool used. And if you think over the last 2 weeks, have you been feeling nervous, anxious, or on edge? Not at all, nearly every day. Not being able to stop or control worrying, nearly every day. Worrying too much about different things, nearly every day. Trouble relaxing, nearly every day. Being so restless that it's hard to sit still. Becoming easily annoyed or irritable. Feeling afraid or as if something awful, a catastrophe is about to happen. Then start to think, if you're more than half the days or nearly every day for these, you may actually have an anxiety disorder, and it might be worth exploring help. It's interesting here because if we look at number 6, looking at annoyed and irritable, a number of people do get really grumpy when they're anxious. And if we're in a relationship and someone's just uncharacteristically irritable and grumpy and fretting, it may be that they do have anxiety difficulties. Next, please. Then the other is depression. And depression, the way we use it as clinicians, very different to lay language. So lay language, oh, I feel depressed, the weather's awful, and so on. But we're referring to clinical depression. And this is a tool that your family physician may use, known as the PHQ-9. Once again, a disclaimer, today isn't about diagnosis, but something to get you reflecting. So do you have little interest or pleasure in doing things? The person may have loved movies a lot before playing sports and no longer does that. Feeling down, depressed, or hopeless. Trouble falling or staying asleep or sleeping too much. Feeling tired or having little energy. Having poor appetite or overeating. Feeling bad about yourself or that you're a failure, a loser, having let yourself or your family down. Trouble concentrating on things such as reading, newspaper, watching TV. And that's an interesting point because where attention and concentration are impaired, memory can be impaired as well. And people say, oh goodness, I don't know, I don't even remember things anymore. It could be a part of a depression. 8, moving or speaking so slowly that other people just have noticed. Or the opposite, it could be really fidgety and restless, and that may happen more in older people. Thoughts that you'd be better off dead, or thoughts of hurting yourself in some way. And if you're ticking every day, nearly every day for these, or nearly all the time, you really should explore that you may have clinical depression and may need help as well. Next slide, please. Seasonal affective disorder. Now, this is something many of us don't think about, but seasonal affective disorder is actually much more common than we think. As the winter comes in, the days get shorter and shorter, there's less natural daylight, and for some of us, our primitive brains go into hibernation mode. We eat more carbohydrates, we put on weight, we feel very sleepy, and it might be a seasonal affective disorder. The great thing is, if this is happening every single autumn into winter, fall into winter, there may be treatments available, like the use of a light box, and we can probably discuss more in the Q&A. And also vitamin D deficiency. So there are also seasonal things, for instance, which will make a great distinction between experiences of people who may have sickle cell in parts of Africa, sun-kissed Africa or the Caribbean, or in Canada during the winter months. Next slide. Post-traumatic stress disorder. Now, a fair number of people are living with post-traumatic stress disorder without being able to put a name to it. And this is a disorder characterized by living with a traumatic or having witnessed or experienced a severe life-threatening or traumatic event. So here the person is, maybe they were in sickle cell crisis, then ended up having an emergency and ended up in intensive care unit. And they're there over and over, reliving with flashbacks of the crash team arriving or an attempt, being resuscitated in a difficult situation. Part of that reliving could be physical sensations, smells, and other reminders, avoiding reminders of that situation, numbing of emotions, or you could have been in a situation, seen someone die, and so on. Now, this could also occur with family and loved ones, a person with sickle cell, finding their loved one dead and living with this trauma. So we really should allow ourselves consider that post-traumatic stress disorder, these symptoms I've described, are a mental disorder and they are treatable with interventions. Next, please. Psychosis. It's a big umbrella term. It can range from disorders like schizophrenia. Some people, when they're in a manic state, may have psychotic symptoms as well, and some people with the use of drugs and substances. But overall, we're referring to a loss of touch with reality. And this can occur in any of the 5 senses, the commoner for many people being auditory, as in hearing things. And when a person's hallucinating, it feels real. For them, it's actually happening. And that can be quite difficult because if I say I can hear chickens and I ask you and you guys say, no, I don't hear chickens. I'm sure I can hear chickens. For me, it's real. Delusions. And a delusion is a firmly held, fixed, quite often, firmly held belief out of keeping with a person's educational status or the culture. So if a belief is held by a faith group, that's not a delusion. However, if, for instance, I told all of you that you may not believe it, but I am Barack Obama, and I'm just your guest speaker, but I'm the president of the United States. And if I really strongly believed it, and you had all the evidence to the contrary, that could be a delusion. And this can be really difficult when a person is dealing with the impact of sickle cell disease and these other mental health sequelae that may occur in some people. Next, please. Stroke and seizures. Now, the impact of this may vary with age, but imagine here's an 11-year-old beautiful young lady who has a stroke at 11 and loses mobility or has a disability as a consequence of that. And what is told could the disability play on that person's day-to-day functioning and growing into maturity? Same thing with the experience of seizure disorders, depending on where in the brain and the toll this may take on mental wellness of individuals as well. Next slide, please. Sleep disorders. Now, it's nearly safe to say all mental disorders or most mental disorders have sleep effects or an impact on sleep. So depression can worsen sleep, either sleeping excessively or having broken or shortened sleep. Anxiety, it's no fun trying to sleep while feeling anxious. Pain, no fun trying to sleep when experiencing pain as well. And sleep apnea. And we may not consider sleep apnea in people with sickle cell, but for a number of reasons, this could be possible. So for instance, the alignment of the mouth or dental malocclusion could add to apneic episodes, or sometimes the medication as well. And some people, it could be through weight gain around the neck, which narrows the air passage. And in sleep apnea, we're referring to a situation where the person pretty much stops breathing during their sleep. Now, this can happen several times all through the night and could leave the person feeling really tired and exhausted day after day. Next, please. Addiction, substance misuse, and we emphasize here perceived versus medical or street. All too often, and many of you would have many experiences of being suspected of seeking opioids. You know, you've decided to spend 8 hours in Emerge just because you want to get a fix. Hey, pain is pain is pain, or discomfort is real. And sometimes also the physician or people prescribing for pain management may unwittingly, or we may unwittingly develop a dependent syndrome. However, a lot of people receiving pain-related interventions are not drug seeking. Many of them don't choose to. And I would ask, the option of having no pain or having pain and seeking opioids, a person with sickle cell disease doesn't delight in the pain. And this is an area where there's been a heck of a lot of stigma, even, and I've heard directly also from physicians with sickle cell disease and how they're treated by their own colleagues, not to talk of members of the general public who may also be stigmatized or labeled. Next, please. COVID, well, we couldn't finish this without the C word. So COVID, the virus itself can affect our mental health. We know that through the 2 years of the pandemic, the restrictions have taken a huge toll on many people's mental wellness. The restrictions, the reduced activities, lockdown, lock-in, access to care and services. A lot of people have had virtual appointments, which brings a whole lot of health inequity. Not everyone has video conferencing capability. And also some of the technology used. It's interesting how some of our new knowledge, well, not new because it was known for about 20 years, that pulse oximeters are not very accurate with black skin. And I'm not saying this as an absolute statement, but there is some suggestion that it would people with dark skin or who may use dark nail polish and so on, the pulse oximetry may not be accurate. Some people hypothesize that some people of color may have had premature deaths because the readings were wrong. I'm not saying this is a generalization, but something to be aware of. Next slide, please. So seeking help and psychological therapy. There's a whole range of psychological therapies. And one of the first steps, whether we're anxious or we're living with trauma or depressed or going through any of the experiences we're going through, is to have a close confiding relationship. Do we have someone in our life, within our networks, that we can confide in? And whether it's our family physician, our faith leader, a sibling, a parent, it's so key, because a few kind words of understanding, empathy, compassion can go a long way. Then we think of the more formal types of therapy through the family physician or a number of counseling services ranging from cognitive behavior therapy and the specific types of psychological therapy that may be available evidence-based for different types of mental disorder. But it's important to consider this, that it's not all about pills, and the types of therapy can be looked at depending on what the type of disorder is. Next, please. Medication. Now, a lot of the disorders I mentioned can benefit from medication, but pills don't give you skills. Pills do not give you skills. So if I'm anxious and I'm using a medication to reduce anxiety, but if the cause of anxiety is not going away because I'm being threatened by someone, or I'm in a difficult relationship, or I'm dealing with racial life events every day, then pills won't take that all away. Same thing with antidepressants or antipsychotic medication or sleep medication. And I would say if you're on any form of medication or using herbal therapies and so on, please let your physicians know, because there might be the risk of drug interactions. In fact, some types of medication can affect our blood counts, and there's a particular antipsychotic medication, clozapine, that may influence blood counts as well. So if you're on medication, please let all the relevant parties know, and please try to identify their drug-drug interactions. But pills on their own won't be the solution. And often we combine psychological therapy, social support and networks, and the great work the SCAGO does with the resource that may be available through peers and others as well. Next, please. Bias and discrimination is real, whether it's unconscious or conscious. People do experience prejudice, have prejudicial experiences and deal with discrimination. You turn up and emerge, and the first thing the person's saying is, oh, that person's got sickle cell, as part of a triaging process. Now, the person may not have even interviewed you, and assumptions already made that, the person seeking opioids, here we go again on a Friday night and so on. So bias and discrimination is real. It could be across the board in our schools, in our workplaces, in our clinical settings. And you heard great examples in the presentation by my colleague, Dr. Ola. Next slide, please. Next slide, please. Right, racism and micro. I put the micro in brackets because for the person going through many of these, they're not microaggressions, they're full on. So micro insults, oh, you know, why are you so skinny? Or goodness, I could break you with my hand. Or just things to do with specific race-related comments. Micro invalidation. I say I hurt, and the person listening to me doesn't really believe me, and so on. Assaults. And these happen over and over and over again in the days, in lives of people of color. Quite a distinction, because this probably isn't happening in Nigeria or West Africa or other parts of Africa. I mean, if you're Black or of color in such a population, but this is a variable that does contribute to emotional mental wellness for many people living with sickle cell. Footnote, not everyone living with sickle cell is Black, and I don't intend it to sound that way, but for those of color living with sickle cell, this may be another variable that may worsen their mental health or contribute to their emotional distress. Next, please. Right, so let's guess, which of these two fists, who of these two has sickle cell disease? Now that's a tricky one, because we can come in with all our stereotypes and biases and unconscious biases and think, sickle cell is equal to Black. But there could be a number of permutations here. It could be the fist on the left, the white fist, maybe the person with sickle cell. The Black fist may not have sickle cell. It could be the Black fist that has sickle cell, or it could be both of them, or it could be none of them. And this is one of the risks that happens over and over and over again when we stereotype and make assumptions that are ill-informed or stereotypical. Next slide, please. So we've covered a lot of areas, and as we prepare to do our question and answer session, and you'll be then free of looking at slides, and we can then really chat and get it even more real for the next half hour or so, I'd like us to do a mindfulness and grounding exercise. And this is one of the things you can do, mum, dad, you can do it at home with the children, you can do it in the office and so on, and it's just grounding you. So when you're feeling anxious, you can pause and settle your mind by naming. So let's try and do this together. So I would like you to name in your head, or you can say it out if you're comfortable where you are, 5 things that you can see. 4 things that you can hear. 3 things that you can touch. 2 things you can smell, and 1 thing you can taste. Now, what's interesting there is this grounding exercise, 5, 4, 3, 2, 1, engages your senses. And it's really amazing how when you're mindful and engaging with this, you can really perceive so many things around you. And I would implore us also that when it comes to mental health in sickle cell disease, that we be mindful too. I'm sure Dr. Ola and I would argue that there's actually potential to have a sickle cell syndrome and that mental health issues and challenges will be part of the syndrome. After all, 25 to 30, and in some studies, even up to 45% of people living with sickle cell do experience depression at one time or another. And a large number also experience anxiety. So we would argue that actually the rates of mental disorders in sickle cell disease sometimes actually exceed the rates of physical health symptoms, yet they're ignored. And we'll use today as a call for action. Next slide, please. Now, this is what today is about. Whether it's a man, a woman, a younger person, an older person, this is what emotional distress can look like. I invite you to look in this person's eyes. And that's what many of us may deal with day in, day out. The hurt, the pain, and all we're asking from those around us, our advocates and people around us, is that they have some empathy for us. They respect our distress, and where possible, they support us so we can be our best selves. Next slide. Great, so time to start chatting. And one of the things I would really hope from both presentations and our discussion is Dr. Ola, myself, and anyone here, if we can come up with recommendations for health professionals, so we can take away today a bucket of recommendations for health professionals so they can better serve us, because I think our score sheet would certainly not be a distinction so far. Thank you very much. Thank you.
Thank you so much, first of all, Dr. Ayonrinde and Dr. Ola, for such a powerful talk. So great on a Saturday morning to be inspired and just educated about information we don't hear enough about. Like, we really don't hear about this. Even I would say in some of the sickle cell handbooks that I have seen, that there's just not even this heavy of a attention brought to it. So thank you for getting us started this morning and for engaging us and suggesting that we actually look at what can we suggest for healthcare providers? Like, what do we want? Let's make this real, like, let's make it tangible. What is it that we're truly trying to say, as opposed to just throwing out stuff? Like, what is the solution? Do we have some hardcore, concrete suggestions? So thank you for that. Let me, first of all, I would like to welcome anyone who is online to unmute yourself. If you did have any questions, comments for our panelists, you can, sorry, for our 2 speakers today, you're welcome to do so. So you don't even have to turn off your camera. You can just unmute yourself. You can use the chat, and you also can use the Q&A if you did have anything. I am going to look, I know there was a question earlier, so I'll look for that. But if anyone else wants to jump in, please feel free to go ahead.
I see a question in the chat that says, does anxiety and/or depression have to be medically diagnosed to know that you're really struggling, or can it be self-identifiable or diagnosed? I would say the first step is self. So if I'm feeling low, I'm feeling worthless, hopeless, I'm in my room, I'm crying, I don't want to see friends or socialize, and I'm sufficiently informed because I've listened, attended the event today, then I'm depressed or I'm anxious. Now, the medical confirmation is actually, that's the diagnostic bit, which may guide specialist intervention. And a way of looking at it also is something like a toothache. If you had a toothache and you had a roaring toothache, you don't need a dentist to tell you've got a toothache. You know you've got a toothache. And I would say where there may be challenge sometimes is how we help health professionals understand what we're going through. We use language differently, and sometimes we need advocacy, but we'd encourage ourselves to be informed, certainly. And I invite comments from Dr. Ola.
Yeah, thank you very much, Dr. Ayonrinde. I saw the question, from the perspective that I shared, the problems that people who live with sickle cell would struggle with, it's not only due to the problems within them. For instance, I would say that depression does not solely lie in the people who live with sickle cell, because there are other social causes of depression. And I would also say that anxiety it does not solely reside in them, because that's the perspective from which I came, having undergone the study. So what we found out is that it's fine to be able to know that one is not enjoying the positive mental health. One can actually use some self-available screens. Just like you mentioned, toothache, but then you could see that, okay, even when I use the GAD-7, I find out that I am having some feelings of anxiety. But like you said, self-care is very important. Then recognize the first thing you might be able to do, like that's the mindfulness technique. It's very important. And then having to link with your social support system, it's also very important. But then if it's really necessary to seek medical care, you might be able to do that if you have some of the cutoff scores. But what I'm saying here is that the way the society has arranged the social structures is to lay the bulk of the blame at the door of the person who lives with sickle cell, and that shouldn't be. There are social causes of depression. I read in someone's Q&A, said that he usually gets anxious, trying to find excuse to go and to leave our workplace to attend something. So what we found in Nigeria, that it's not about workplace, but it's about schools, because it's been found that the physiology of children with sickle cell is that they urinate quite frequently than others. So what we did as a policy in the school is that they should allow them more times to visit the toilet, because they find out that teachers shout on them. They don't allow as a policy that this is this person. And so this person doesn't even have to take excuse to go to the toilet. So once that policy sets in, you find out that they are able to do that. Then another thing that we're trying to address, it's about the fact that a lot of them fall sick during exams. So there are some major exams. Can they also have a policy where they can sit for exams if they miss the exams during the normal time? And because these are social arrangements that, if they are put in place, would actually reduce the tendency to have what we call the societal cause of depression and anxiety. Because if you are afraid to go, and because they will say, oh, you've taken so many excuses to visit your doctor, then it will affect your salary. Definitely you will develop anxiety. And then if you can't even see your doctor, but that cause of anxiety is not within really you. It's caused by the social arrangement that needs to be changed. So rather than say, oh, just go and be swallowing drugs, there might be a point where a person would need to have medications. And that is where we need the medical personnel, the health professionals, to understand the Venn diagram that Dr. Ayonrinde drew, where he showed the interlocking between the physical, the social, psychological, and spiritual, because that assessment is quite key in understanding the cause of what you are struggling with. I would struggle if I know that I cannot get more than 3 permissions to visit my doctor in a year. But because of the nature of who I am, I live with sickle cell, I may have to see my doctor more frequently than what my workplace policy does. So because of my own condition, there would be a need to change that workplace policy. And once that workplace policy is changed, then that would have a lot of positive impact on the social cause of my anxiety. And so if I am to use that one, then I would have more areas of thinking that, oh, could it be now me? Or could it be just my interpersonal relationships?
Yeah.
Let me stop there. Thank you very much.
Yeah, there's some exciting questions coming in. I think they're firing in, so we're all pumped up till the end. Yes, so Karen, I think there's some in the chat or Q&A, and then I see Ms. Lanra's hand up as well.
Yes, I'll let Ms. Lanra go first. I do see her hand up. And then Carla is going to take care of the Q&A to help me out. Thank you.
Thank you. Thank you to our great speakers today, Dr. Ayonrinde and Dr. Bola. Every time I listen to you, Dr. Ayonrinde, I learn something new. Thank you so much. We really appreciate this. I wanted to make a quick comment and buttress what Dr. Holler said. So you're so right about the what are the programs that we have in place to support individuals with sickle cell disease in the school system, in the work system, and so on and so forth. So in the school system, even here in Canada, what we've done is we have created what we call sickle cell management protocol. And that protocol we've shared with many school boards to support students. So I totally concur with yourself to share with them, for instance, an individual with sickle cell disease should not be placed in cubicle classrooms because of the temperature. It's not very consistent as it should be, versus they should be in the regular classrooms where the heat can be controlled much better, especially in the winter time. If they do not want to, to go out and play or something like that, let them be. Or they need to go to the bathroom, let them have as many bathrooms breaks as they need to, because we know that individuals with sickle cell may not be able to hold their urine as much as other their peers without sickle cell. So I think these are great things, but I think these things need to also be done. I don't know how Nigeria is, but in my mind, it shouldn't be just one school or that school. It should be something that should be kind of national, in scope, to ensure that no matter where an individual with sickle cell is, if they're a student, we are preparing them for success, right? And they will not have the school environment perhaps induce crisis or anxiety and so on and so forth. I think, and I think you mentioned the Sickle Cell Club. I think that's kind of linked with the Sickle Cell Foundation of Nigeria and stuff like that. I think it would be great if there's more work that the foundation can do to really improve this across the country and not just in Lagos or, some part of the country. But thank you so much for that comment. Thank you, Dr. Holler.
Perfect. Thank you, Ms. Lan, for sharing your thoughts. I'm going to get Carla to go ahead and pick some of the Q&As and to present a question. So it's only because for some reason I just can't see it, guys. So we're going to get Carla to read them out.
Okay. Can everybody hear me okay? Okay.
Yes.
So we have a question from Sandra Newton. She said, your talk helps us understand depression as an understandable response to an invalidating environment and experiences. Could more be shared about the specific supportive behaviors, words, actions, practical efforts on the part of close family and friends that reduce stigma and contributed to better mood, depression outcomes for those in your study or studies? How do we improve those immediate environments?
Well, thank you very much. That was a very brilliant question. And one of the things that came out, because the model of the research, it's about the researcher, which was me, not actually really guiding them, that they need to actually be in the driver's seat. And what they started talking about in the focus group discussion was majorly, one of the things is that they feel people stigmatize them by the name that they call them. They call them sicklers. And they want that changed. So, and what they decided was that the people need to have literacy about the sickle cell. I mean, we have what we call mental health literacy. So they find out that they need to have, I mean, people need to have awareness of how to talk to someone who lives with sickle cell, because they would rather prefer people to address them as someone who lives with sickle cell or who has sickle cell, rather than be called a stigma. So one of the things is that. Then the other things has to do with the way the family members actually deal with them, because some of the family members who don't understand will think that they are pretending, particularly when they have pain. They think that they don't want to walk. They think that they are being given space. So I think they were saying that it's not, and a lot of people are talking, I mean, people need to banish sickle cell. It's not that they don't. One of them said, I mean, I'm a bit distracted here, said she understood that she was even more powerful than even others because she could bear pain. She was involved in a road traffic accident. She had a broken arm, but she could see people who had AA, whose blood type was AA, and that they were all whimpering, they were all crying, but she was there. She was able to stand. And in fact, somebody even told her, did you have this fracture? She said, yes, I did, but I am. And that also shows her that doesn't even want to change to another person without sickle cell, because she feels that that experience shows her how to master pain in her life, which is a powerful rhetoric from her. But where we're going is that they said that the family needs to understand how to care for a young one who has sickle cell. So there are different psychological techniques, different parenting techniques, different techniques that they would want parents of those who have sickle cell to have in order to create a positive, nurturing environment for children. Another thing that they actually also wanted, because a lot of them, if you have sickle cell in Nigeria, you can't have any health insurance, which is very, very bad. So they asked, because stigmatizing, it's against the human rights. So they are also fighting for that. So that also came out from the study. So I think, let me just allow, those are some of the things that came out from my study. Thank you very much.
Great, thank you guys. Thank you guys for posing those questions and for really generating some great discussion. I'm really, Dr. Ola, you really express your passion for this, and it helps. It's just so amazing, because the things you're bringing up truly are not aspects I've really considered myself. And I think I feel like a pretty good sickle cell advocate, very knowledgeable in nature, and, partner with individuals living with sickle cell, but you've really highlighted things that I've not thought about. A question that we have been posed, and this one is, how can we as loved ones best support the mental health of folks with sickle cell? Did we answer? I don't think we answered this yet. How can we strike a balance between understanding compassionately without overwhelming them?
Yeah.
I don't know either of
But
you.
that is a great question, and I think in several ways. First would be to validate. Validate the person's experiences. If someone's saying, "Mom, I hurt," or "Mom, I'm embarrassed," or "Dad, I feel this way," let's validate. And where possible, which is difficult because if it's a family member, you may be hurting too. And watching or seeing a child in distress or pain can be very distressing as well. But let's validate the experience as real. The child with sickle cell among siblings, you recognize the person has sickle cell, but you're not trying to treat them as if they're different. Let them play with the rest. Let them have a childhood. Let them be as authentic as they can be. And not, the goal isn't to wrap them up around in cotton wool or cushion them from everything, but to be there for them in some of these situations as well. There will be opportunities, certainly, to advocate for them. But again, what you don't want to say, as Dr. Ola was saying, is, "Oh, you're the sickly child," or, "Oh, I've got 3 normal children, and then my 4th one is the sick one." Or, "Oh, we have a nickname for this child at home. We call him Yellow Eyes," and so on. That hurts. And what we can do is unwittingly hurt the child at a time, or the person at a time of emotional need. If it's a spouse, for instance, the spouse may be dealing with really difficult situations from the workplace, the social circumstances we've heard a lot about. And the understanding is not that the spouse is being lazy. You know, I don't mean, you know, it's not laziness, it's just that they're not well. And we should be careful about our critical comments. So words can soothe, but words can also harm. And I'd say choosing our words carefully and making our words a balm. Goodness, where did that come from? Words can soothe and words can harm. Choose them carefully and they could be a balm. I don't know where that came from, but it sounded okay. Yeah, thank you.
Thank you. That was great. That's something else I'd read too in the literature, just around destigmatizing language that can be used between healthcare providers. So that same, without intentionally meaning to transfer that to someone, but just the word selection, whether, you know, you pick narcotic versus opioid, like narcotic has a negative connotation to it more than opioid, even though, you know, opioid crisis does lend also to, you know, to drug seeking, but you know, substance abuse versus drug seeking, that just depends on your language. So really words are 100% important. Okay, well, sorry, Dr. Ola, did you want to add anything about that last question? We do have another one that I can present to you guys. So I don't know if you want to jump in on that one, or I can present the next one.
No, just present the next one. I think it's been fine. Thanks.
So the next one is from Sandra. I am also troubled by the degree of suicidal thinking that the study reveals. Are we talking about this problem enough in our care circles, from clinic to home to social support circles, in your view? Please share, if there's time, how we may better screen for and respond to this significant area of concern. Thank you.
Problem, because the stories that I heard, in-depth interviews, showed that there are other dimensions of suicide that most people will not understand. For instance, when I shared the story of someone who was very assiduous at her work, staying late nights and doing things without knowing that she was actually willing to die. So from these experiences, what we need to do really, because it's a very sensitive area that needs more careful examination. For some people who have suicide, they would, when you ask them, because the training is that asking about whether, so you want, I mean, asking that question, that are you having suicidal thoughts? It's great. It elicits a lot of responses, but for such people who want to remain invisible, they might not actually answer yes. And that is because, and I found out from my work, it's because there are sometimes they see me as they. That's people out there, and we as we. It was when we got more, have a lot of rapport, that they now, and they knew that I also have family members who have sickle cell. So they were willing to share more with me. So, and I think the trick to it is being a friend, being a partner, rather than, oh, this is the doctor, me, I'm the patient. That actually could create that can increase the eating numbers of people that may also have. Those are the things, yeah, but then there is a need for more study. I myself, I don't understand it, but it's something that needs to be studied more. Thank you very much.
Yeah, just I'll try and keep this to 60 seconds. Just add into that. In a world where people may occasionally live with hopelessness, a sense of worthlessness, with a health condition that many other people in some parts of the world associates with mortality and morbidity, death thoughts lurk, and suicidal thinking can be part of natural problem solving. And I really think as health professionals working with people with these complex needs at times, that we must allow ourselves to ask these questions. And as you said, Dr. Ola, seek and will find. And sometimes we create such a barrier of professional stigma that doesn't enable the disclosures. So great question.
Thank you. I agree. That was really such a good question. What can we be doing differently? I think about a number of things. I wonder a bit, like research-wise, or raising awareness-wise, have we spent so much time raising awareness about painful crises that has now become the main association with sickle cell, that we, all of these underlying issues are underlying, that they're not really up and front and center. Because if you look up sickle cell, you ask someone, what is the primary concern? It tends to be vaso-occlusive crisis, acute care. What do we do for vaso-occlusive crisis? Yes, what else do we do for everything else that comes with living with sickle cell? So I'm really enjoying learning and thinking about different ways that I too actually need to, because that's how I've also framed anything I speak about. It really comes to, I'm generally usually talking about educating healthcare professionals about what to do when they arrive and emerge. But before they arrive and emerge, what do we need to do to prevent that even from happening? I want to please ask, before we run out of time, I see we have 4 minutes. There is someone, yes, this recording will be available online, no problem. Please just check our website, or you can definitely get in touch with one of us to ask at SCAGO. Perry asked a question about life insurance. And so I know OHIP, no problem. Third-party insurance, I could see, depends on how you answer the questions. If you would get third life insurance, I kind of feel. I'm wondering about life insurance. So, do people have some input on the challenges? Are there challenges faced by those living with sickle cell with getting life insurance? I could see it. I think anyone with a condition, especially a chronic illness, or it's looked at as a chronic illness, would have some challenges, but I don't know if there's anyone online or if either of you have any experience around that.
Yes, the life insurance one is a big one, and it presents opportunities as well. A person living with a chronic health condition, let's say you're traveling abroad, or you've declared sickle cell, and you say you're going to another part of the world, insurance may raise premium. And I would say we owe it to actually advocate that some insurance policies could be discriminatory. There are human rights issues, and this again is an opportunity for SCAGO to get in that space, advocate, get human rights in, and really fight that fight that living with a condition, a genetic condition, should not lead to further discrimination, further financial hardship, and so on. Because as Dr. Ola said, we can build social structures and systems around people that have a big toll on mental health. So yes, some people may pay higher premiums as they would for chronic health conditions, and we've got to get that fight in. The numbers are small, but the advocacy has to be loud. And if anyone can do it, Ms. Lanre can. So let's do it.
I love that. That is such an awesome way to bring us to our end. I do want to just highlight a comment, because there is someone who has put a comment. I don't want you to think we missed your comment here. I'll read it out loud. You know, sickle cell plays a huge role in mental health. For me, it's even more apparent in adulthood when you realize it affects your job, prevents you from moving up in the company. It prevents you from getting life insurance. It prevents you sometimes from being in close relationships, prevents you from planning ahead, such as vacations. You don't know when you'll get sick. The majority of psychologists or therapists don't know how to address / help with such stressors. And, you know, this also goes along with benign hematology on a global scale. This idea, you know, there's not a number of providers who even know about sickle cell, period. Never mind now the layer of mental health that goes along with that. So thank you, Emily, for raising that. And one last comment, what we need is our care professionals and those in our lives to listen to us. Instead, some brush us off and tell us it's all in our head, nothing is wrong, and this continues until sometimes it's too late, when things get bad and physical symptoms manifest. We need people to hear us, listen, not even hear you, right? You actually want people to listen to you, right? And be believed and check it out instead. I 100% agree with that too. And I actually say that when I go to visit patients, I'm like, just listen to what they're saying. Actually, just don't. Pain tools is a separate thing. We're at 12 o'clock, so I don't want to, but pain tools are another thing. I think the numeric pain scale is completely useless in any pain assessment as a healthcare provider. I don't know why we use it. Self-assessment. Listen to your patient. What are they saying to you? And use that as your evidence of how to treat them. So I want to thank you, everyone, for joining today. We had a nice number of participants steady throughout the whole time. Dr. Ola, Dr. Ayonrinde, thank you for waking us up and getting us excited about what we can add on and look forward to as another advocacy lens or pathway that we can take with SCOGO. So thank you, everyone. We can give a virtual round of applause to our two presenters. And again, guys, have a wonderful, wonderful weekend. Thank you.